introduce myself. So I'm Mark Pauly, Mrs. Pauly's favorite son. And I'm actually delighted to be able to chair this session on the business case for changes in nursing to improve quality and value. I objected to Heather. We should have met in the Hamilton room, right? Because he was the Secretary of the Treasury. But here we are in the Montpelier room, so we'll have to make do with that. And I am very excited to hear this panel. I think I may have warned you a bit this morning. Although the inquiry program is ending formally, there is much more research is needed, and this is one of the topics on which it may come as no surprise that I believe much more research is needed. I was somewhat, and I think we were somewhat frustrated in about the last 3 RFPs for inquiry. We asked for work on the business case and on the consideration of costs as well as outcomes, not exclusively. Economists are not like that. We believe God's house has many rooms, but one of the rooms is the Treasury, and so you do need to worry about things like that. And I was a little distressed, but actually was much cheered up by the paper that Olga, Doug, and Kevin have written, because there was, in the research, unbeknownst to me, a lot more findings that are going to be germane to the business case for changes in nursing to improve quality and value than I thought were there. So there's still, as I'm sure they will tell you as well, a lot more to be done, but the basic questions at least have been started, and once academics start answering questions, others are convinced they have the wrong answer, and so there'll be the usual interchange, and hopefully this will be a process that won't stop. We're going to follow the rubric of previous times. There will be a brief presentation at the beginning of sort of a summary discussion. Then I will ask a few pointed questions, but then I'll just turn things over to the panel members. Well, no, I think the sequence is a brief set of commentary, a summary commentary, comments by individual panel members. I get a chance to ask my 3 most burning questions, and then throw things open to the audience, and then we'll have a final summary. Just to describe who is going to be talking to you. Olga Yakusheva is Associate Professor of Economics at Marquette University, on leave at the Yale School of Public Health. This year, her program of research investigates nursing workforce issues and hospital readmissions. Her inquiry study was with Marianne Weiss at Marquette, which found that when hospital units had more RN hours per patient day and fewer overtime hours and fewer vacancies, basically that helped to reduce readmissions because the discharge teaching was of higher quality. So both the qualitative measures and finally the punchline were all positively affected, thank goodness, by higher inputs of nursing care. Doug Wholey is Professor of Organization and Management at the School of Public Health at the University of Minnesota. He and I are both team guys, both in the figurative as well as the literal sense. We're both interested in the behavior of teams, and he's particularly interested in transprofessional teams that provide care for disadvantaged individuals, whether disadvantaged economically or disadvantaged in terms of health. I'll skip a few things here in the interest of turning to the people who really have something to say, but I do need to mention that Doug's inquiry study with Joanne Dish found that nurse-physician co-leadership, believe it or not, improves heart failure patient and staff outcomes by improving team cohesion. Probably the reverse is true. When there is team cohesion amongst nurses and physicians, outcomes are improved. And finally, Kevin Frick is a health economist and professor at Johns Hopkins Bloomberg School of Public Health, a student of my former student, Rich Hurth. So Kevin becomes doubly blessed. He has taught and conducted cost-effectiveness analyses throughout his career and has extensive experience working with nurses, and he's worked with the interdisciplinary research group on nursing issues within Academy Health and within the National Institute for Nursing Research Advisory Council. His inquiry project was with Linda Costa and Bob for Wholey, and it evaluated the effectiveness of nurse-pharmacist clinical information coordination in improving, I'm sure it must say, patient outcomes. So I'm delighted to have this wonderful team, and I will sit down and turn things over to Olga to get us started. I think we eventually have a slide with questions on it, right?
I think it comes in the middle.
It comes in the middle, okay.
I don't think it matters much. Good afternoon.
Not the answers, so.
That's right. It is wonderful to see so many great people in this audience. And I'll tell you, we're so very excited because our team, the panelists and myself, we're really excited and looking forward to a two-way learning process in this audience. Because as you might have noticed, Mark is an economist, I'm an economist, Kevin is an economist, and Doug is an economist in denial. So, and a lot of you might have heard that economists know very little about how things really are, and that is true. I faint at the sight of blood, so. But jokes aside, we really are very excited to hear about your take on, I guess, our perceptions what the business case for nursing really ought to be. And we're interested in hearing all sorts of experiences. We're interested to hear your thoughts, your positive experiences, and what you think might work and what you think has worked, but also what hasn't worked, and what your perceptions of some of your barriers may have been to implementing changes in nursing practice to improve quality and value. So what is the business case for nursing intervention to improve quality and value really means? What we're going to talk very briefly about today is sort of defining the main concepts. Just yesterday, I walked around and asked a few people what they thought a business case really meant, and I got all sorts of answers. So somebody said that it probably means how much we should pay nurses, or how many FTEs we should budget for. Somebody said that should probably mean the return on investment for an extra FTE. And there was one person said it was that 100-page document that chief nursing officer produces and nobody understands and reads. So we're going to touch on, I guess conceptually on the idea of the business case for nursing. We're going to talk about some of the barriers that have been identified to trying to make a business case for nursing. We'll talk about some of the ways to potentially overcome these barriers, and that's where we will really need your input and your ideas and your experiences. And we'll conclude with discussion in the audience. So why do we need a business case for nursing? And I think that is, as an economist, to me, it's always clear that before you do something, you have to evaluate the costs of something versus the benefits of something. I think after I have been exposed to nursing, to doing research in an interdisciplinary team, it is not, I think a lot of people feel like there is a lot of research that supports the idea that nurses produce a huge positive contribution to patient care. And a lot of this research came from the INQRI-funded studies. However, before we can take this research and put it into practice, we have to make sure, or at least a lot of the hospital administrators feel that we got to make sure that there's a positive impact not only on the quality of patient care, but also on the bottom line. Okay? Or at least the negative impact on the own bottom line is not prohibitively expensive. So I think that's why we're going to talk a little bit about how do we define the business case? Why do we need to make the business case? And the whole idea of the business case, simply put, is that you have to try to evaluate the benefits of something versus the cost of something. And as long as the benefits exceed the cost, well, then you have a business case. And it becomes very difficult from the perspective of trying to make a business case for nursing, because while the costs a lot of times are easy to measure, it's the extra pay that you have to you have to budget for, or you have to hire somebody to cover somebody else while they're getting their bachelor's degree. So the costs a lot of times are easy to measure. However, the benefits, the improvement in patient care or patient experiences, quality of care, reduced burnout, a lot of those benefits are very hard to quantify. And And they're very valuable, tangible, important benefits, but they're just very hard to measure in dollar terms. And that's one of the reasons why it's so hard sometimes to make a business case for nursing. Another reason is that when we try to make a business case for nursing, it's hard to figure out what perspective we should take to try to figure out, whose costs are we going to measure and whose benefits are we going to measure, right? Because if an intervention costs the hospital but produces benefits for the patient that are not being reinvested and then in some way not being put back into the hospital's pocket, well, it becomes very difficult to convince hospital administrators that is a cost beneficial or quality improving intervention that should be implemented. So we'll talk a little bit about, obviously not a comprehensive review, just very few highlights of what were the current state of knowledge and the business case for nursing care stands, and what are the future steps. What is it that we need to do to really try to show and prove to hospital administrators and the general community that nursing has value that is tangible and could be measured in dollar terms. So these are some of the questions that we hope some of you will raise during the discussion. Some of this we have an idea of how to answer, and we attempted to answer them in the paper, but we really need input from you to try to answer those questions. What makes a business case for nursing-based intervention from your perspective? What is it that you as nurses or hospital administrators, people who really do hands-on care, what is it that you feel should be included as an important aspect in trying to measure or trying to establish the business case? What are some of the pros and cons of investing more in nursing care? Obviously, benefits, people always talk about benefits of having better nurses and how that translates in better quality of care. But there are some costs, and some of those costs have been sort of alluded to during the morning session today, where if you put $1 into nurses, you take the dollar away from something else. So we'd like to get your input on those pros and cons, how you feel them or think of them. How do we develop evidence base for the business case in nursing? What is the critical and very important evidence or parts of evidence, pieces of the puzzle that we're still lacking? How do we align incentives to improve nursing care? Because if something is good for the patient, or let's say something produces cost savings for the insurance company, but the upfront cost of the intervention is being imposed on the hospital, well, how do we align those incentives? And what are some of the necessary contextual conditions or organizational features that could potentially either serve as barriers or facilitators to nursing change? So those are the questions that we hope to have a discussion of. And some of the most important points that I think that we try to make in our paper, and we'll keep on coming back during today's conversation, is that it is very challenging to make a business case for nursing. There are a lot of studies, and partly Mark was alluding to that. He was excited to see all of the studies that we pulled up that were trying to make a business case. There's probably a lot of studies out there that were trying to make a business case, and maybe you have done some of that. And it's just really hard, because it is hard to prove from the organizational perspective that it really is cost beneficial, or there is a positive return on investment when you invest in nurses, for those two reasons that I just alluded to. Because some benefits are very hard to measure, and because a lot of those benefits, they're outside of the hospital system. They go to patients, to the families of the patients, or they go to the insurance companies, and they're not being reinvested or captured by the hospital. So hospitals incur the cost of nursing change, and there's got to be, we should think of your idea of ideas to try to create some schemes to put some of those benefits and reinvest and put them back in the hospital's pocket to create this incentive, to align incentives for nursing change. And the bottom line here is that a lot more research needs to be done to try to fully capturing all of the aspects of nursing change, its beneficial aspects, and maybe potentially not so beneficial aspects, to try to make real case for investing in nursing change that improves quality and value. So with that, I'm concluding my introductory remarks.
Okay, thank you.
Thank you.
I think my role here is primarily to direct traffic, so I think we'll go to Doug and Kevin for additional comments, and then throw the throw the discussion open to the floor.
Want me to go ahead?
I think
Yes.
there was no questions.
Pardon?
Okay. No, that's all right. I can. From my perspective, even though Olga says I'm an economist in denial, I sort of treat myself as a mongrel. Do a lot of things. And I don't know if many of you remember Paul Harvey and the rest of the story. Yes. You have to be fairly old. And the cost effective...
Although he lived forever.
Yes, I do remember.
Yeah.
I still remember hearing him a couple of years ago, and I mean, my gosh. So the cost effectiveness to me is part of the story. That tells you whether an intervention works or not, right? Tells you whether an intervention is cost effective. But to me, in a business, if you're trying to make a business case, you're not looking at just the intervention. You're looking at your bottom line. So if you're in a primary care clinic, it's how is this thing going to play through to the bottom line at the primary care clinic. If you're in a clinic in a hospital, or in a ward in a hospital, it's what is the total effect of this intervention on everything. Now, so we have to evaluate more than just the cost effectiveness. You have to build this into sort of the business model that the organization is running, and there's a couple levels on that. And the first one is that context matters for implementation, which the implementation session pointed out. If you go to Pawson and Tilley's realist evaluation, the context, mechanisms, outcomes model, we can give you a story about advanced practice nursing in primary care. So you embed them into primary care, you have them seeing patients. And there's a great study in Australia. Some of the primary care practices made a lot of money, things went better, because the APNs delivered at least as good as care as primary care physicians. Most of the time it was better, okay? But in some of the practices, you had the physician who felt that he had to stand over and watch the APN deliver the care. Now that doesn't really implement it very well, and the other thing you have is when you have a physician seeing the same mix of patients as the advanced practice nurse, you don't realize any economic gains. If you have the advanced practice nurse seeing people and passing them up the line when necessary, you start to make money. So slight differences in the context and the implementation. In our study of heart failure care, we find that nurse leadership drives interdependence. Interdependence drives respect. Respect drives learning behaviors, improving the practice. And now, physicians are high status, and they can create respect by how they treat people, right? They signal an environment that you're supposed to be respectful and civil. So that's another avenue to respect. Both of them working together, right? Lead you to more respect, leads to more learning, leads to people being prepared for patient encounters, leads to better patient and staff outcomes. So how do you create a context where you get nurse and physician co-leadership? Okay, and one of the things is supportive facilities. So that's one story. So the context that you implement these interventions really affects how well you implement them and how well they're going to work. And so that has to be part of any model for the business case. The second thing is the externalities. And I think Michelle Ballas, if I remember right, yesterday was talking about delirium in hospitals, right? And it would take a lot of time for nurses to do these things. And she made a comment that was really great. What will be left out if nurses are required to do this? It's called a negative externality for economists, right? And so if we just take these things and we load more work onto nurses, well, then we're going to ask, what's left off the table? What have we lost? And we've got to price that in. Now, positive externalities, we talk about care coordination. And I agree that that can make patients better off. But who else does it make better off? It makes some other person in the organization, a physician, a CMA, another nurse, not have to deal with spin control due to waste because coordination wasn't done accurately, right? That's a positive externality. Doing the job right with care coordination standardizes work and makes everybody else's work easier so they can see more patients, right? So to do this full business model, to really understand it, you can't just look at the cost effectiveness of the intervention. You've got to start to say, what's the context? Will I be able to implement it? What are the positive and negative externalities out of this. What am I gaining? What am I losing? So what's my total bottom line at the end of the day? And to me, if I was running a primary care clinic, that's the way I would think about this. I wouldn't think about just the intervention. So broadening the cost effectiveness idea into a broader whole business model.
Kevin, what's your take on this?
I think that a couple things that I'd want to add just food for thought to start with is really the issue of, I guess there's two issues. One is a lot of these studies are small studies to start with, and then there's the issue of scalability. And one of the things that I've found in a number of different types of studies that I've been involved with through INQRI and other changes to nursing practice is that what starts out as a idea that seems very effective, might even look very efficient when it's done on a small scale by an initial research team, there's a whole host of issues that come along with then taking it from a small scale to making it organization-wide, or from one organization to other organizations, which comes to the issue of context that was mentioned both by Olga and by Doug. The other thing that I think is really important to think about is, a lot of what we're talking about now are things if we're on the hospital side, where we want to reduce length of stay or prevent readmissions. And certainly the INQRI project that I worked on with Linda Costa and our colleagues, the idea of better medication reconciliation and trying to avoid readmissions and adverse events and a variety of things like that. One of the interesting questions is if you open up these hospital days by keeping people out, what happens to the beds on those days? And so this is just sort of another take on Doug's point about what's the whole business model. If you have fixed resources that suddenly become available, how are they going to be used? How does that affect your bottom line? Is there a way to use that productively? Would a hospital actually shut down some of the beds if it had a big enough impact on things? And overall then, thinking about that impact. And so it's really just elaborating on a couple of points that were already raised, but just reiterating the fact that if we don't take the whole effect on the enterprise into consideration, not only are we not giving a good answer to the managers and other decision makers who need to think about things, but the decisions that they do make may end up being the wrong ones for the business.
Thank you. Before I go to questions, I wanted to offer my 2 cents worth, as long as I'm standing up here. This comes from actually I was worried about the question that Zeke was asked this morning. If we get healthcare costs under control, we'll have to lay people off. Won't that be terrible? The answer to that question usually is you should lay off the MBAs, and I teach MBAs, so I don't want them to be laid off. But the one version of the business case is I will call the vulgar business case version, which is what tends to occur to them. Of course, ours are more perceptive than that, but it is just the simple story. Okay, say it's a nursing intervention, it has an upfront cost. When the dust clears, did it lower total cost? Does it have, or to put it in the jargon, does it have a cost offset that exceeds in present value terms the initial cost? And for many people, that is sort of the beginning and the end of the business case. I guess the authoritative version of that, according to me, is almost always if you can reduce costs by your intervention, it probably is a good idea, and it probably is a legitimate business case. I'm saying probably because 4 economists, 5 opinions. It is conceivable that you may be able to save on hospital cost by imposing costs that patients may have to bear when they go into the community, and so it may not reduce total cost. But in most cases, at least that I've looked at, and in the cases that I've considered and that we've considered as part of the INQRI program, if either sometimes there's evidence and sometimes we hope, we hope beyond hope that this intervention will not only do so much good that it will improve health outcomes, but it will also do enough good that it will reduce total cost. So that's sort of the vulgar version of the business case. If it lowered, and the flint-eyed CFO that I know some of you have had to confront kind of wants to know that. That's sort of the bottom line. Then there's the sublime version of the business case. And the sublime version actually is a translation of what the paper that the 3 have written talks about. It takes as the benchmark measure cost effectiveness of an intervention, And I don't know how many of you have descended into that, that version of the netherworld, but in cost-effectiveness analysis, we usually measure things by dollars per quality-adjusted life year. And for some reason which nobody knows, we think if you can produce an additional quality at $100,000 or less, you're golden. Now that's sort of the most sublime social version. They only use that in the UK. We don't do stuff like, it's not American to do that, but they do it. But the main point I wanted to make is that if an intervention doesn't reduce cost, and cost effectiveness only makes sense in talking about interventions that don't reduce costs in aggregate, because you're trying to compare the cost with the benefit. If the cost is negative, there's nothing to compare. So if the cost is positive, you want to basically ask, is the benefit worth it? And the sublime version of the business case is to say, yes, the benefit is worth it, and the reimbursement to the hospital, however it comes, ought to capture the dollar value of that benefit. In fact, that would be the ideal reimbursement system, according to us. So the cases that I know of where we've seen an intervention from the INQRI projects or other projects where it looks like it's cost effective, but the business case isn't there, it's because there's a glitch in the reimbursement mechanism which isn't paying for outcomes that are of positive value. And of course not enough they just be a positive value. Nobody wants to sit next to me at a dinner party because I tell them, contrary to what Zeke said, that some things in healthcare actually do some good, just not enough good for the money. We have to stop doing them too. But if it does enough good for the money, then there ought to be a way on God's green earth to somehow structure reimbursement to get that as not just a good thing to do, but a thing that would actually pay. And then it's just a question of modifying. Of course, it's easy to say, and I can say this because I have tenure. It's just a question of modifying the reimbursement system to pay for all this great stuff for what it's worth. Anyway, that's my 2 cents worth, so I just want to throw that in. And now, questions or comments? We really do want to hear from you. Yes?
Kathleen Stevens, thanks for being gentle. I'm a non-economist person, and I look forward to really studying your paper. So you may have indicated where this particular term goes, but I didn't catch it because I'm not an economist. But what about the idea of cost avoidance and how, you know, I come from that a lot from patient safety and the cost avoidance aspect of that. Can you help me understand that a little bit further?
Sure.
I'll take that to start with. So it's actually the project that I was on with Linda Costa is a great example of that. So the idea there was to reconcile the medications to avoid the cost of adverse events. And so the way that you would incorporate that into a business case is you would say, okay, if we weren't doing this reconciliation, how many adverse events would we expect? And then we have to have some way of saying, what do we expect those adverse events to cost? And there's things in the literature, you might have your own hospital data, understanding what those adverse events would cost. Then what you do is you propose or you study an intervention, you look at the costing of that intervention, and you say we're going to compare how much it costs to have a nurse and a pharmacist working together with this information system to reconcile the medications on admission and on discharge. And then if we do this right, and we look at how effective it is, and we see how many medication errors are reduced, and then we can use that to project to how many adverse events would be reduced, we would compare the cost avoided with the extra cost and make that assessment. I mean, it would be great if it was as simple as, and if the costs avoided are bigger, we then implement it. It's often a little more complicated than that, but that's the real comparison. It's the benefit side. Cost avoided are essentially another way of thinking of a benefit in a cost-benefit type of analysis.
Thank you.
You're welcome.
I would like to, sorry. An example of cost avoidance that you probably are very familiar with if trying to avoid late fees. If you return your book to the library online, you don't have a late fee, so you've just avoided that cost. You save the money. It's like having your money in the pocket instead of giving it to somebody else as a late fee. And another study, so we did a study on readmissions where we showed that better nursing care lowers readmissions. And readmissions are really costly. So by lowering the rate of readmission, significantly bringing down the readmission rate. In our study, we have projected that it would have saved the hospital system over the course of 1 year, $11 million. So that was the cost avoided, meaning that they kept it in their pocket. They would have had to pay it, but the cost was avoided.
But you don't want to let them box you in. So suppose you show there is some cost avoided, but not enough to pay for our pharmacist, say. All we do is avoid drug-drug interactions. We save some money, but not enough to cover our cost. But it's plausible to argue, I think, that even if it was free, you wouldn't want to have a terrible drug-drug interaction or failure of people to take their medications. And so that's the part that somebody ought to be willing to pay extra for above and beyond the cost offset. So the cost offset or the cost avoidance, I guess we need common terminology here, just like in implementation, are things that you may hope for, but even if you don't quite make it, as long as you can make a strong case that the benefit you're providing is of high value, you still ought to be able to make a business case. Sharon?
I'm primarily based at the VA, which is a globally budgeted system, and as we try to push translation out, the thing that we're getting, sort of reinforcing here, is the managers, they say, we don't want cost effectiveness, we don't want societal, we're concerned about those, but what we want to know is what Doug was saying in terms of how it's going to affect the bottom line, and not just the bottom line, but over time. So you figure, okay, what are the startup costs, and how are we going to make the return? And so that, and what they're asking for in relation to what Mark is saying is, what is it actually going to cost me to do this? And I may save money, it may cost me money, but I want to know it, and I want to know what the timeline is, so that I can make an intelligent management decision as if we're going to invest those resources. And in terms of that, there have been some relevant points that I just want to reinforce that have been made in terms of things like Kevin mentioned, okay, if we have fewer patient days, what happens to those beds? So the cost avoided, if you reduce patient days, is not necessarily what those patients cost in aggregate, because there are fixed costs that may still be borne, and so you have to try and tease out what are the actual budget impact on the organization, and it gets tricky at times, but as you start to do this, the more that you can give managers the information and you can convince them, you've carefully thought this through, these are the impacts, these are where they are, when they have, if you've made a more detailed case, but if you've laid it out for them carefully, they're much more likely to say, pull the trigger on it. And it may even be that it's going to cost them something, but there's going to be a benefit, and they'll see other intangibles in terms of the benefits.
I want to add something to that now that Karen has brought up dynamics, because a guy named Wes Cohen developed this idea of absorptive capacity. And by becoming engaged in learning activities, quality improvement activities, you improve the current state, but you also improve your ability to move to the state after that. And so it's a positive feedback process on learning. So if we just look at the world cross-sectionally and look at these learning adventures, learning efforts that we have and engagement of the staff, we might say, no, it doesn't pay. But if you look at accumulating interest over time, you go, well, 10 years down the road, this has really become a very huge effect. And sometimes it seems to me the organizational part of this, of how we can build an organization that's a learning organization and the long-term payoffs, could be credited a bit more in some of the activities associated with organizing.
Yes.
I have a question. If you become good at what you do as a hospital, for example, if you become good at something, a procedure or management of a certain disease, and that generates a certain buzz and reputation for the outcomes that you generate, even though you might lower your readmission rates and everything, is it counted into the risk-benefit cost analysis whether or not you generated either more demand for your services or another market share that can generate more money for you? Is that part of the?
I'll punt to the economist.
So I think it depends on how good whoever that does the cost and benefit calculation for your particular organization, it depends on how broad of a scope and how good they are, because it definitely should be counted. And in fact, there is research that shows that even patient satisfaction and patient loyalty and referrals can significantly increase your market share and reduce your market share and profitability if they're low. So there definitely is a link. Now, I think when people are asked to do those cost-benefit computations, and I've done a few of them myself. Those things are the ones that go at the bottom. So you produce the number and you say how much it's going to cost you, and how much you're going to. Usually, it's cost avoidance. So, but how much money you're going to save as a result of this intervention, or what is the return on investment is over the course of the next year, 2 years, 5 years, 5 years. And then at the bottom you say, however, we did not include this, we did not include, because those things, they're hard to measure. There is some research that shows that, yeah, there is a link. Now, like Doug was referring to the fact that a lot of the research is very context specific. So just because, let's say it was right in California, people feel they may not be right, whatever. So those are the things that should be counted if you know exactly what what the dollar figure there is that they produce. But most of the time, they just get listed at the end, saying that those are also potential, like cherries on the cake. What is it? Cherry on the cake? How do you say it? No, cherry what? Cherry on something.
Okay. Probably on an ice cream sundae or something.
Or something like that. There is an expression, right?
The
Cherry on top.
The cherry on
Yes.
top.
Yeah.
Right. So.
Yeah, I just wanted to add a brief comment. I mean, one way of thinking about it is that you can think of sort of concentric circles or boxes. The smallest one is just for the cost of the intervention and anything that's directly affected by it. That's what most cost effectiveness analyses you see in the literature are focusing on. The second one then is the whole organization, so talking about issues like Karen raised and I had raised about the backfill and other issues about what happens to the resources that are then freed up, but still within the organization. And then the biggest concentric circle, which you just raised, is the issue of, well, can we take the whole market into consideration? And each of the, I mean, it's hard enough sometimes to do a good one for the smallest circle. Getting those two bigger ones, as Olga was saying, is an even bigger challenge, but that's where the point that I raised and that Mark had also commented on, the fact that just because you don't get a positive net benefit or it doesn't look cost effective or cost saving when you're only focusing on that smallest circle doesn't mean you shouldn't do it. And there's a whole variety of other inputs into the decision-making process.
Just follow up one in terms of the circles and all of that is that, I'm coming from the VA, we're an integrated system, we've got everything. Most healthcare organizations in this country are not that way. It's a hospital, and the benefits may accrue to a different payer. And it goes back to what Mark says in terms of the incentives, but that you need to consider that it makes it much tougher in some settings than in others to demonstrate the case, depending on where the benefits are accruing. But there are ways around this, as Mark and the other economists will confirm. You can design incentive structures for anything. It's just a matter of getting them in place.
Yes, sir.
So I haven't read the paper, and maybe this is in there, but the notion of a business case for nursing sort of implies an alternative, and I guess is the alternative no nursing? Probably not. Is it various levels of staffing and that sort of thing? I guess ultimately, kind of with some economic background, I think of the production function and trying to kind of put this in the context of a production function, let's say a production function for a hospital. I guess I'm wondering if you could comment on, are we really talking about kind of measuring what economists would call the marginal revenue product of nursing? In essence, what its value is relative and therefore kind of what the wage should be, which gets into considerations of what nurses can do relative to other types of labor, and which, if we can come up with efficiencies or innovations that make nurses more productive relative to other types of labor, maybe there should be kind of a change in kind of how much we pay different types of labor and different types of specialties. So I guess I'm wondering if you could comment on, are we really talking here about the production function and whether it's the interaction of nursing with other inputs, whether it's the substitutability of nursing for other inputs, or whether it's the wages and the value of nursing, or sort of the optimal level of nursing hours, relative to other things. In essence, when you're talking about the business case, are these really the heart of the matter in terms of the way economists would think of a production function that we're getting at?
Okay, that's sort of where I was trying to go, is that in the heart failure units, how productive a nurse is depends on how the cardiologists are. Okay, you can't separate these things because they're both inputs that are required to do the job right. And if you have the story I had about the primary care, if you have the physician standing over the nurse, it doesn't do you much. If you have a physician who trusts the nurse in that context, you can get the gains. So, yeah, you're trying to talk about how the relationship among the people and how that affects their marginal productivity in an optimal way. So if the physician is letting the nurse do the job in the primary care clinic, the physician can be seeing more complex patients, and you're actually increasing the total production of the firm. Okay? So you can't separate nursing from everything else, the standardized systems, the facility support, and other things like that. You have to take that all into account to figure out what the marginal product is.
I would
Yes.
like to- oh, sorry.
Yeah, go ahead.
I was,
I was curious, how do you view, where do you view nursing in terms of where it stands on the value chain?
Loaded question.
Kind of based on your, his question and your most recent comments on not being able to separate it out from the physician.
I would love to have the data to estimate that. Okay, I think they're necessary parts of the production. You have a division of labor. You have all sorts of people that are doing work. You have pharmacists. They are valuable. You have nurses who are valuable and I would say necessary. And if you want to estimate their marginal product, you could try to do that if you had good enough data. But it's sort of like my example I'd have from my academic unit is that we have some people who are rainmakers who want to take credit for all the grants they bring in, and my comment is, you're not bringing in any grant unless I'm on your project doing things for you to back you up. And so I'm going to sort of back off that question because to me they're all necessary. They perform different roles, and then we're into a much different question. Okay?
Any other thoughts on that one? Yeah.
yeah, we just
That's a
like,
really good question.
very good
It's
question.
not as it should be. That's the short answer.
And I think it is related to the question that was just asked from, and I can see from in the back. What is it? How do we define the business case for nursing? And I should have probably specified this. And so there are two aspects here. You know, the contribution of nursing, and then the value of a change in nursing. Okay, and I think that's where, when we first started writing this paper, we had a little bit of a confusion amongst ourselves as far as what is that we were writing about. Because I think that our first version of the manuscript literally read, we can't do without nurses, so there's not even any need to make a business case for nursing, so let's just stop at this. And then we didn't know where to go with this. And so then we thought about this, and we read a little bit more carefully, or, you know, what our paper does and what we're talking about today is the, I guess, the business case for a change in nursing. Okay, so nurses are just as integral to the health, to the delivery of care as gasoline to getting somewhere. Right? You need a car and you need gas. You can't do one cannot do without the other. But if, for instance, and the way that we're trying to approach this problem is in a way that would be beneficial to a hospital administrator who is faced with a problem, whether they should try to increase the level of education of nurses, or increase the scope of practice of nurses, or reduce overtime, add another FTE. So all of those marginal changes, that's what a change in nursing. How is it beneficial, and how do we go about figuring out, should we do it or should we not? So that's what this session is about, and we're not, I think that would be way beyond anybody's scope on the planet, maybe besides Mark, to figure out the value of nurses altogether.
Well, I'd love to run the regression that Doug is talking about. But I'm not sure.
Exactly what I was thinking. We do these regressions where we can, say that this contributes so much to the variance, et cetera. It'd be really interesting to take a look at that from a professional standpoint with nursing and physicians and RTs and PTs. But the comment I had is I'm struck as I was just listening to these last comments on the discontinuity, I guess would be the right word, in this whole idea of trans or interdisciplinary work and research. And yet when we look at the monetary component of that, or the economic component of that, the reimbursement, the realization of return on investment, et cetera, is not dealt with in the same manner. And to me, that's what some of what is it nursing's really contributing to in these quality outcomes. But to what point is nursing realizing those gains? And then I think of, but is it really important that anybody realize the gain when it should be the team and the bottom? So I would be interested, I don't know if I'm articulating this well, but any of your thoughts there that we have this kind of disconnect between this big push and realization, actually, that nobody can work in a silo rarely independently. And yet the whole economic side of it is built that way.
Well, the whole field of economics is built on ceteris paribus. Leaving everything else constant will change this one thing, and then we know what to do with it. But if it's not like that, then we really it's hard. It's hard.
Yeah, and I'd actually, it's interesting to think about whether economics as implemented through the INQRI program in particular really is as separate as that. I mean, there are certainly studies that I have been on where people have said, it's the day before a grant's due, I want to put in a little bit on cost effectiveness analysis, and they hand me the data at the very end and say, do whatever you're going to do with it. And those are not productive relationships. I mean, sometimes they end up in published papers, but they're not productive relationships. And I would say one of the things that is true about the relationships I've developed through this program, and a number of others that I've developed, is it's people who want to talk about the economics from the start. Now, if the economic analysis is still basically an economic analysis because that's the main set of techniques for the methodology, that's the way it's going to be for that method and for the results. But I think two things that economics benefits from and can also then interact with the other researchers is that if the discussion begins at the very beginning of the project, then there's input into, well, what really should we be measuring? And here's the things that if I was left on my own as an economist trying to think about it, I might think of. But working with my nursing and physician and pharmacy and all the other colleagues, here's this bigger set of things that's likely to be affected. And we can go back and forth. Well, is that measurable? And what are we measuring? And those sorts of things. That's one way in which the economics has really become integrated in. I think the second way, is reflected by some of the comments and questions that have been raised, is that it's not just about, are the benefits bigger than the cost at the end of the study? Or if we're doing the cost effectiveness analysis, is the dollars per quality less than 100,000? It's that extra interpretation, that extra step that you can take when you have the input from the clinical colleagues that says, well, this is the start of the interpretation of why this might be useful, but there's all these other things that should enter into the process. And so while the methods may be relatively standalone, I think that the inputs into it and the interpretation of it are actually, at least for the set of projects, fairly well informed by others, so that it's a more integrated way in which economics has been used for these projects than for many others.
I think there's one other way to get at the balance between physician and nurse pay. And if you look in England at their quality outcomes framework for the primary care clinics, they have a rule that they pay the primary care clinics as a clinic as a whole. And it's been interesting as they've emphasized more chronic care management, and advanced practice nurses have come to the fore to run clinics, disease-specific, condition-specific clinics, do care coordination things. In some of the GP practices, nurses have become partners with the doctors, which is basically, you're in business, you're not somebody we employ, you're our partner. And then they have to figure out how they share income among all the partners and all the staff. But I think that's another way to look at how changes in the contribution of various types of people within a clinic are valued. And that would be a great way to study to see which clinics do that and how nurses actually, the relative value, let's say, of nurses and physicians and how it's structured on a little microenvironment.
So with what I perceive as a sea change in patient-centeredness, how does that or should that affect an economic model? See, that's what I thought.
Well, I mean, I don't know, I mean, on one hand, I think the economic model is there's a set of principles to do the economic analysis, okay, but in England, it's the story that I had is, as they moved up to, they actually have as part of their quality measurement system that they pay the practices for is patient satisfaction, okay, and also outcomes and other things. And that's where you see nurses actually rising in status and becoming more important to the production function within the clinics. So as you weight different things, like the patient satisfaction, delivering patient-centered care, that should enhance the opportunities for people who are more crucial, which I think are nurses, in making sure that that care happens.
So, one directly to that, and that is that if you have an effect that is positive in terms of the patient-centered or patient satisfaction, that is going to affect the ongoing business viability of that practice. To go back to what Doug was saying, what really matters is, what's the bottom line in terms of the business viability? And just sitting here, I have a totally different comment that I want to make. It's in a little bit different direction in terms of, it occurred to me in listening to these, and this is also the perspective of the spouse of a nurse executive, in a hospital, when they have to cut budget, where's the first place they come? Well, the biggest line item in a hospital is the nursing budget. So the first thing they're going to do is they're going to cut the nursing budget. And in terms of changing that mindset as an appeal to everybody else in this room that is doing studies, the more that we can get results out there about how improvements in nursing can positively affect the bottom line, we may start to affect that mindset that we need to cut the budget, let's cut nurses. And without thinking about the fact that there can be adverse consequences of that. And, it's just the more we get out there that shows the positive value of nurses may help change that mindset some, and then over time have a bigger impact on policy.
Just to briefly comment on the previous question, and Olga might want to comment too. I think one way of interpreting how a change to a patient-centered system could affect the economic model is just to think about the context. I mean, essentially what you're doing is you're changing the context for implementation. And if you start to think about those outer circles that I mentioned earlier, particularly the market circle, then a patient-centered context, particularly if what patients care about is actually then affecting their demand for the services, as it should, then it's going to change the interpretation of how what you're doing is going to affect the demand and affect your bottom line.
And I think that is very true. And in fact, a lot of hospitals now are going to the system where the quality measures for hospitals are recorded online. And I think over time, patients will be more aware of different costs and quality implications for going to different hospitals for elective procedures. And patient satisfaction with nursing quality, the quality of nursing care they receive, some of the major tools that are used now by hospitals, some of the major scales, they do include that one aspect as one of the quality indicators. And things like that over time will tend to elevate the scope and the importance of the nursing domain in the delivery of patient care. And that's where you really, as nurses, you will start seeing more and more benefits.
Peter?
Hi, I'm Peter McManaman. I'm the health economist for the American Nurses Association. It's been a long time since I was at all close to being a theorist, but my recollection is that multi-factor production functions make a lot of these questions sort of up in the air. But there is a different tradition in economics, which is storytelling. And there's a story about a farmer and driving a horse-drawn wagon, and he's got a 2x4. And what I want to ask is there something in the business case in what you've done that would suggest how big the penalty or the reward has to be for the hospital in reducing readmission rates? My guess is that CMS is going to write regs with insufficient penalties, that they won't be large enough to have the effect of the 2x4 on the side of the head of the horse. First of all, what would be the size that would be necessary to draw attention? Because I think in reducing readmission rates, you're really talking about increasing nursing staff.
Mm-hmm.
Now, Now, the other question I have, which is a little bit related, I don't know what the answer to is either. Would it work better if it's a penalty for having readmissions, or if it's a reward for reducing readmission?
So I will give my perspective, and then I can defer to. So there is some behavioral research in economics that shows that penalties work better than rewards. Financial penalties. If you're thinking about raising your children right, then the carrot works better than the stick. But if you're talking to an administrator who's looking at their bottom line, the stick works better than the penalty, than the carrot. Although that's behavioral economics, because from an economic point of view, there should be no difference. But behavioral economists find that there's a difference. As far as how fat of a stick it needs to be, I don't think we really know a lot. And I think hospitals themselves don't really comprehend the extent of the problem they may be having. Every single study that I've been involved in that involved hospital data, the first thing that when hospital administrators got me on the project, or my colleagues got me on the project, the first thing that hospital administrators want to know from me is what is their readmission rate, because they have no clue. I mean, literally, they just don't know this. And it's this lack of awareness of the problem existing, I guess, of the extent of the problem in the first place that needs to be solved first, before we can figure out how big of a stick it will take for them to try to solve this problem.
I would just like to add Paul Heidenreich, one of our team member runs the VA Heart Failure Query, has a nice paper out that shows very high readmission rates are associated with higher mortality rates. So what do you want, dead people or readmissions? Okay, and so he came out last year, and so it's not at all clear that lowering readmission rates is an unalloyed good.
Yes.
This is more of a comment, I believe, but...
in the form of a question, it's fine.
You have shared information about building a business case for nursing services in the acute care setting. My comment is really related to other environments in which nurses practice, including the long-term care and home care settings. And I think that there's a crying need, especially in the long-term care settings, to provide the business data that long-term care administrators need to make a more rational and informed decision than they currently do in most long-term care settings.
Yes.
I think.
Actually, I think you could extend that argument to public health nursing.
Absolutely. Absolutely.
So
no trouble.
I'm going to tell a story, because I think it actually works better both in substance and in form in long-term care based on care for my mother, which is when we looked at different long-term care settings, there were variations in nurse staffing and quality that were perceptible. Maybe I'm supposed to be an expert, and the family puts a lot of burden on me, so I asked Mary. And variations in price. And basically, if you were willing to pay more, you got more high-quality nursing care. And in a way, may upset the rest of you, but this is kind of how economists think it ought to work. That there ought to be a trade-off, and if nurses more intense staffing provides additional values, and this is the economist version of consumer-centric or patient-centric care, meaning it's a value to consumers, and I hate to say it in terms of their willingness to pay or their insurer's willingness to pay on their behalf. Then you can see how the case can be made. Why? And it's certainly true that although there are some embarrassments, of course, in the quality of care provided to chronically ill elderly in the U.S., there certainly are some examples of places that are high quality but high cost, and that's sort of how it would come out.
But oftentimes they are looking at the cost of just increasing numbers. And I believe that increasing mix, for example, having a geriatric nurse practitioner on site in a facility would decrease the amount of time it takes to have an evaluation after an adverse effect event, and to get results. Just getting an X-ray done takes almost 48 hours in one of the best settings in Illinois.
Prove it, and I'll pay for it. I think that's what the CFO would say, at least the wise one.
Right.
Of course, he'd probably say, "I've heard that story before," but nevertheless, I think that is a legitimate point, and And there is, legitimate research that can answer at least some of those questions. Other comments, questions? Yes.
I'm a nurse practitioner and a lawyer. I am not a nurse scientist, nor do I ever want to be one. Okay, but I do have the opportunity to work with some very scholarly scientists, and we have been working on medication discrepancies, and in particular, looking at tracking what those discrepancies are, and the more likely than not, result in incidents of those medication discrepancies in actual lawsuits and case law. Could you give us some insight into how you would actually capitalize on that information as far as the likelihood of, let's say, for example, an insulin medication discrepancy resulting in an actual lawsuit? How do you track those costs? How would you be able to make the business case, if you will, for reduction of litigation against healthcare facilities or practitioners related to those likelihoods of harm?
I'll start. I mean, certainly in the study that I was involved with, we were mostly tracking just the medical care cost and not the potential cost of litigation. My inclination would be to approach it as an insurer would and say, what is the change in the probability? Do we have any idea what the size of the payment amount would be? And use that then to take a cost avoidance approach and say, if we reduce the probability by 10% and the average payout is $500,000, then that's a savings of cost avoidance of an expectation of $50,000 each time. But that's a very simplistic starter view of that. There may be other comments.
I think there's if you give me your card, there is some research that I've just recently came across where they do look at litigation and the reduction of cost of litigation. They did not look at medication discrepancies, but they did look, I think, at patient satisfaction, and they found a link between patient satisfaction and reduction in litigation. And they did a cost-benefit analysis, and they found it cost-effective. So I could forward you some of that information.
Let me ask Mark a question. Are there any cases in that where an insurer might come and say, we're going to lower your premium? If you can show us that you're reducing the risk to the patients, we'll lower your premium for malpractice suits.
Well, there probably are. It's a big country, but the general the general gripe against malpractice insurance, at least physician malpractice insurance, is that it's not experience rated to any great extent, and therefore, in a way, it's kind of the worst of both worlds, because they have malpractice insurance, physicians worry less about negligence, but because the insurance doesn't punish them for negligent behavior, negligence is not deterred, doubly undeterred. Yeah, so you could imagine an enterprise calculating, well, it's going to cost us this much to avoid medication discrepancies, and it will avoid this much cost in expected damages. And and if the second was higher than the first, they would pay for the intervention, the nurse that helped do this. If this is what I get from my colleague Patricia Danzin, who's the world's foremost authority on malpractice, if we thought that the tort law system actually imposed damage costs that were correct measures of social cost, it would be beautiful. Of course, there couldn't be insurance then either, because that messes it up. But against the cost of damage. But it would work out. The glitch, of course, here as in the reimbursement system is that the real-world reimbursement system and the real-world tort law system doesn't always impose dollar amounts of either benefits or costs in proportion to the truth, but in proportion to something else. I think we probably need to finish up here. I'm getting those signals. That's my chance to say Zeke isn't the only optimist. I'm actually an optimist, especially now as we move into, hope, thank God, a much more fluid consideration of how healthcare organizations and people might be paid for their services. There actually is, I think, a really significant opening for us, all here, to take the kind of research we have on the contributions nurses make to quality and turn that into a payment system that does strengthen the business case for doing God's work. So I certainly hope that'll happen. Thanks, everybody.